Today, we are on site for Day 2 of the Community Oncology Alliance's annual Community Oncology Conference in Orlando, Florida. We will be recapping some of the top news presented each day during the meeting, and soon we'll speak with Dr. Debra Patt, Vice President for Policy and Strategic Initiatives for Texas Oncology, and Dr. Jeffrey Vacirca of New York Cancer and Blood Specialists. Welcome to AJMC On Location. I'm Jamie Rosenberg. The second day of the meeting focused on cancer drugs and different strategies for addressing their costs. There was a session on CAR T-cell therapy, which explored different clinical and reimbursement challenges associated with the treatment. In addition, there were sessions on the adverse impacts pharmacy benefit managers have on cancer care and the effect of step therapy and utilization management on access to cancer treatments. We also got an industry perspective on price, cost, and value of cancer drugs. Read coverage and watch additional interviews from the meeting at ajmc.com. Here with me now to discuss some highlights from Day 2 of the meeting is Dr. Debra Patt of Texas Oncology. Thank you so much for being here with us today.
My pleasure, thank you.
So to start off, I was hoping you could kind of paint a picture of the landscape of oncology right now. Can you give us an overview of some of the most important trends that are affecting patients and their providers?
Sure, so it's a tremendous time of change in oncology care. We see so many changes before us. Changes in therapeutic innovation, which have been fantastic. The advent of immunotherapies and oral oncolytics have led for many patients cancer to become a chronic disease like hypertension or diabetes, requiring chronic management, and many cancers to be cured. So it's a tremendous time of innovation, which means we have a lot more therapies to juggle and a lot more opportunities for patients. The natural consequence, though, of all of the innovation is that drug prices have increased considerably, and there are a lot of policies to try to influence reductions in the total cost of care. So at the meeting today, we address a lot of these issues, talking about advocacy around policy issues that might impact the ability for cancer patients to receive care, and a lot of work on enhancing the value of cancer care delivery. So it's an interesting time, and we all need help in navigating the landscape before us.
Great. And something that's in the news often is the opioid epidemic. We hear a lot about this. Looking at the crisis in regard to oncology, how is the epidemic impacting oncologists? Are there policies being implemented to address the crisis that are in turn kind of restricting access to opioids for cancer patients who need them?
It's a great question that you ask. So the opioid epidemic clearly is a problem. Oncologists definitely want to be part of the solution. But sometimes the best laid policies have unintended consequences. And what we find is when people have restrictive prescribing requirements in the states to try to restrict opioid problems like diversion and abuse, they can result in appropriate patients not being palliated. So as a cancer specialist, probably one of the most important things that we do is to control pain and suffering among patients with advanced cancer. And any policies that may be implemented that would restrict that would be challenging. So we've seen some state policies that dictate a 7-day dispensation limit. Other state policies that recommend checking a prescription monitoring program, which is another web-based program. What we find is that all of those policies can be limiting in oncologists giving cancer patients appropriate palliation. And so a lot of our national societies have come out with guidance to carve oncology patients out of those considerations. So ASCO, the American Society of Clinical Oncology, the Centers for Disease Control, and the American Medical Association have all recommended that for patients with cancer and for patients on hospice, that they're exempted from those kinds of policies to control opioid abuse. What we see in the states, though, unfortunately, is that all states haven't exempted cancer patients and hospice patients from those opioid controls, and we think that's a problem. We've seen the natural consequence of that in some states is decreased appropriate prescribing in affected patients.
And now looking at a program that's gotten a lot of news coverage also in the past year or so, and has had some debate around it, is 340B. Looking at the program, what are some of the biggest unintended consequences that have happened in recent years?
So the 340B program is a good program to try to allow hospitals that are seeing a disproportionate share of poor patients to purchase drugs at a discount and provide care for patients by stretching already thin resources. The challenge is the growth of that program, which has been facilitated by a lot of policy changes to try to allow programs to qualify that didn't have pharmacies. The hospitals now are able to have pharmacy relationships with sometimes up to 50 pharmacies with any given one hospital. That's resulted in growth of the program, which is now a $24 billion program annually. It's a challenge both because when you have so many drugs purchased at a discount, you can imagine that if a manufacturer sold 30% of their drugs at a 50% discount, they would have to raise the prices of other drugs in order to maintain a stable profit margin. And so this program in its current form contributes to drug price increases. I think the other challenge in the program is that because there's not a statutory mandate on how those funds are spent, there's variability between hospital systems. On some hospital systems that are using those funds to provide care for poor and underserved patients, and other times it may go to fund other strategic priorities. Because it's not statutorily mandated, and HRSA really doesn't have any teeth to enforce how hospitals manage those funds, it provides some problems. And the natural consequence then is that some patients that are poor and underserved don't have access to care even where a 340B hospital may be present. So those are challenges. But as you mentioned, there are upcoming potential policy changes that would help and help reform the program so it could be implemented with its original intent. In my opinion, adding transparency to the program to let us know sort of where funds are going, accountability to make sure that there is a priority to stretch those limited resources to serve underfunded patients, and then to make sure that the definition of the patient is right. Right now there's pretty limited guidance, and a lot of people can qualify as patients and apply the discount. That definition of a patient needs to be more strict to make sure that the program is implemented appropriately.
And these different consequences, have they had a spillover effect onto community practices? Are they impacted by this?
They are, because the program has created a large economic incentive that facilitates consolidation. In many markets, we've seen that community practices that are independently owned will then align with the hospital system because of this economic benefit. And that's a challenge. As a natural consequence of that, over the last decade, about 50% of community oncology practices that had been independent then became in alignment with hospital systems, which is a challenge in terms of taxpayer dollars, because care in commercial patients in the hospitals in comparison to the community outpatient clinic is about twice as expensive per episode, per disease, per day. And so that side of service shift has economic consequences for the country.
Right. And so you mentioned different opportunities for improving the program and that there are some policies. What are some policies that are being introduced, and do any of them look promising?
So there are some policies already that have happened. So CMS gave out guidance to change the nature of reimbursement among patients on the Medicare program that we're seeing at 340B hospitals, to change reimbursement from a historical average sales price plus 6% to average sales price minus 22.5%, recognizing that many of those drugs are bought with a 50% discount, so it still gives maybe around a 20% margin while it's variable for each drug. But what's happened with that policy is it's been challenged in the courts, and right now it's unclear what the outcome of that policy will be. In my opinion, what would be beneficial to the long-term health of the program would be to heighten transparency of the program, to understand really how much funds there are in a given site, where those funds are going, to heighten accountability of the program, to make sure that those funds really are going to serve underserved patients, and then to make sure the definition of the patient is right.
Perfect. And so earlier this week, after multiple delays, HRSA launched its online tool for determining the maximum that pharmaceutical companies can charge for drugs. So what do you think the impact of this will be? Do you think this will have a positive impact? Do you think it'll be in the short term? Do you think long-term effects will kind of be different?
Well, the HRSA's guidance really suggests a ceiling price methodology for patients, for 340B hospitals when they purchase drugs. I think that this kind of guidance is likely to facilitate transparency, and in my opinion, we need to have more transparency in the program. So it seems to me that that's likely to be beneficial, but the jury's still out.
Perfect. Thank you so much.
Sure, my pleasure. Thank you.
So sitting down with me now is Dr. Jeff Vacirca, New York Cancer and Blood Specialist. Thank you so much for sitting down with us.
Thanks so much for having me.
So earlier today, you had a session on the impact that pharmacy benefit managers are having on cancer care. What has the impact of this been on patients and their providers?
This is truly an atrocity. What we're facing is a delay in care for patients as PBMs try and capture every prescription possible because of the vertical integration they've set up with their own specialty pharmacies. Now, they've not done this to lower prices. This has actually caused prices to go up for patients. But even worse, it's caused delays in patient care to the point where we've seen deaths from patients not getting their drugs on time. This is very similar to what we see in hospital systems with the 340B program. Whenever there's a lack of transparency, you have bad guys playing bad games.
And with increased scrutiny on these PBMs, do you think we're likely to see any efforts put forward that will improve this and kind of mitigate and tackle these issues that are coming from them?
Well, we're seeing a couple things. We're seeing both a state by state address of this. So recently Ohio went back after CVS Caremark when they found out they were being fleeced for about $220 million. And now New York has some legislation coming forward that will do virtually the same thing. It'll take the spread back from what the PBMs are making on prescriptions on Medicaid patients and bring that back to the state, so it's not funding profits for the PBM. And then on the other side of it, on the national side, there is some bipartisan bills being put together for more oversight and transparency, but we can't be naive. We know that these are multi-billion dollar companies with 4 companies right now in charge of 266 million patients in the United States.
And what other market forces, such as practice consolidation and different reporting requirements under payment models, are impacting community oncologists?
Well, there's a million attributes to this. On the PBM side, what we see is a made-up fee called a DIR fee, where because on the prescriptions that you run through the physician-owned pharmacy, CVS can't charge you, or any of the PBMs can't charge you on a per-script basis, they make up a fee to charge back to you. This is just a way for them to take back any profits that the practice may make on a prescription and bring it back into the PBM, who actually hasn't done anything to facilitate the patient care.
And what about hospital consolidation? Is that affecting community practices a lot?
It has. What we've seen over the last 10, 15 years is these mega hospital corporations get put together. Now, when this originally started, the intent was, wow, if we have all this horizontal integration with all these systems coming together, we'll better be able to facilitate patient care and we could lower costs. What they did was exactly the opposite. They actually used this as leverage to go back to the payers and say, hey, look, we own all the hospitals in this area. We want 4, 5, 6, 7 times Medicare rates. It's driven up costs of care dramatically. And then they use the other side of it, which is they get these remarkable discounts on 340B drugs. And we know 80% of these hospitals don't even meet the minimal requirements for charity care that they're supposed to give out. It's a horrible thing that's going on. We're doing everything we can at COA to shed the light on this because it's affecting patient care. It's not just affecting the cost of their care and the accessibility of their care, it's truly affecting their ability to get care.
And what about these different reporting requirements under these payment models? Is that adding to the burden and the stress providers?
It seems like everything possible that could be added on top of our backs to prevent us from providing patient care comes every single day. There's new requirements from the PBMs, from the payers. Now you would think sitting here, and I'm in New York, I have 139 different plans. It's insane, right? How could one practice have to manage all that different paperwork? Do you know that the forms that we file with each of these insurance companies are different? There's not even a universal form that we can use to file with the companies to get payment on time. And the reason for this is very simple. If an insurance company is able to not pay you for as long as they possibly can, all they're doing is floating money on our backs and keeping the interest.
And now looking at these different challenges, last year, New York Cancer and Blood Specialists, along with West Cancer Center and Texas Oncology, announced their partnership, One Oncology. How is this partnership addressing these different challenges facing community practices?
I'm very privileged to work with Jeff Patt from Tennessee Oncology and Lee Schwartzberg from West. They are probably two of the most brilliant minds in community oncology care in the country, and the rest of the folks that have been brought onto OneOncology, it seems they've left no stone unturned to find the best people available. I think it's going to be a remarkable company. We're starting off to a great start, and I think what we're going to see over the next few years is OneOncology will serve as the North Star. They're going to change the delivery model in cancer care. They're going to change the accessibility for patients to get the newest in research drugs available. And we're going to do everything we can to be on the forefront to change this paradigm that's been created with things like PBMs and hospital consolidation.
And through this partnership with these different practices, how are you going to be able to identify best practices for these different challenges?
Part of that is up to Dr. Schwartzberg. So when you work with such a brilliant clinician like that, sometimes you sit back and you just say, Lee, you take care of it. So what Dr. Schwartzberg has done in conjunction with the executives at OneOncology is create a council, which will be called One Council. That will take a physician leader from every single practice to come together and come up with what are the best practices from the best practices. And from those, we will create things like pathways and research programs that we can really, from the ground up, distribute to all the practices within the system.
Great. And do you think this partnership will also help practices with the shift toward value-based care and value-based contracting?
You need scale to do these things. Even my practice with 90 doctors and across all of lower New York, it'd be hard for us to manage this. So you need scale, you need a platform, you need the intelligence behind that platform to be able to put together these contracts and to work nationally with managed care leaders. We're very fortunate. Our CEO, Tracy Ball, has years of experience in this field, and he's got the connections to reach out directly to have us have the ability to sit down with the leaders in the insurance field to come up with these partnerships to better care for patients at a lower cost.
Great. And the company is also partnering with Flatiron Health to utilize its technology platform. How will utilizing this platform allow practices to enhance the quality of care delivered to cancer patients and also keep them up to date on latest clinical and operational data?
So you really need to start with a common platform and clinical integration to be able to do anything. Can you imagine if we're all on different EMRs and different PM systems, how we could accomplish anything across the country? It's just not possible. And we're very fortunate to have Flatiron as a partner. There is no other software in oncology that can even come close to what they're capable of doing. And if we look at what their breadth is and what they intend to do over the next couple of years, it's remarkable. So we're excited to work with them. We're excited to develop research programs with them, analytic programs with them to further enhance their EMR so we can better care for our patients.
Okay, and what do you think is in the future for OneOncology? Where do you think you guys will be in, say, 2 to 3 years?
It's interesting. If the growth stays the way it is, it's limitless. I think there's potential for virtually every practice in the United States that's based out in the community to have a place within OneOncology. On top of that, we're actually hearing from a lot of hospital-based practices now. What we've seen over the last couple of years is physicians have gotten tired of the domineering, autocratic forces that are behind them every day, and they want to work in an environment that is going to allow them to practice medicine the way that they want, to have people behind them to help them make the right decisions, and to not worry about everyday business issues. And that's what OneOncology will do.
Great, well, thank you so much.
Thanks so much for having me.
That's all from the Community Oncology Alliance's annual Community Oncology Conference. Join us again May 19th to 21st when we'll be reporting on site at the International Society for Pharmacoeconomics and Outcomes Research's annual meeting being held in New Orleans, Louisiana. Thank you for watching AJMC News Network. I'm Jamie Rosenberg.